Definition of posture is that which your grandmother used to scold you about, which is being upright, and how being upright can help avoid certain problems. In addition to like looking especially beautiful, like my niece Lucy here, who is, if I hadn't told you already, a dancer with the Milwaukee Ballet. In general, the consequences of what we call poor posture is having a moment arm of external torque. So if there is a large external moment arm, then that increases the need for muscular tension to maintain a functional posture, such as keeping the head upright. And that causes a chronic high joint pressure, because remember that the main source of joint compressive force is not gravity, but active muscle tension. And further, joints thrive on high compressive force as long as they're being applied, as that force is being applied cyclically. If it's being applied chronically, as we learned, that leads to joint degeneration. So if the muscles are not able to sustain that functional posture, such as keeping the head upright and other things too, which we'll talk about over the course of the next several minutes, then what can happen is plastic deformation of the connective tissues that hold the joints together underneath the muscles. And that leads to further joint deformity, pain, and disability. We'll start at the top of the body, thinking about the neck. So one thing that is really common is what we call forward head posture. And the fellow in the picture here has a forward head, but not an especially severe case of forward head. But in his case, for instance, there's a moment that is introduced if our head is exactly on top of the neck and neck exactly on top of the shoulders. Then that moment is minimized. Remember, we don't change the mass of the head, but we can eliminate the moment by stacking the joint segments just exactly on top of each other, which actually rarely happens. We'll talk more about this over the next few minutes. But a moment is introduced that causes high muscular tensions needed to maintain the head upright, which increases the joint compressive force. So in this case, the size of the moment is the angle going from the base of his neck at C7 up to the center of mass of his head, which gives us an angle of 30 degrees. So if the mass of his head is 50 newtons, then the moment arm is in this case, the way this is set up, the sine of 30, which is 0.5 times 50 newtons for a total of 25 newton meter moment arm of external flexion. Another common postural problem is a thoracic kyphosis, or an unusual forward bend of the thoracic spine. So here is an illustration. This is actually an illustration that was used in the introductory slide of this talk in the last lecture of a fellow with a very pronounced thoracic kyphosis. So the thoracic kyphosis puts tensile forces on the posterior supporting tissues, such as the supraspinous ligaments, the infraspinous ligaments, all the thoracic spinal extensors, and compressive forces on the discs and vertebral bodies through the external moment and through the internal moment, which we're going to talk about in just a little bit. So first, the external moment. Here we see the center of mass of the head, and there is the moment arm. So we have a considerable moment arm if the kyphosis is that bad, perhaps 15 centimeters or 0.15 meters, times the 100 Newton force of the head. So we remember from static equilibrium equations, if the external moment is 50 Newton meters, and the internal moment must also be 50 Newton meters. However, the muscular moment arm is way shorter than the external moment arm. So if the muscular moment arm is 3 centimeters or 0.03 meters, then the muscular force that's needed to maintain a fellow upright with this big thoracic kyphosis is 50 Newton meters divided by 0.3 meters, or 500 newtons. So his total force on those joints of the thoracic spine would be 600 newtons. The next postural problem which we'll consider is scoliosis. You've all heard of scoliosis, and it's a lateral curve. It's actually a lateral and rotary curve. We'll talk more about it next semester in kinesiology. I think almost certainly you'll talk about it in musculoskeletal as well. But it requires treatment if the lateral curve progresses beyond 25 degrees, because that increases the external moment arm, and once the curve is that high, the load required for further plastic deformation of the vertebral column decreases dramatically depending upon skeletal maturity. When we have bone that is growing, that bone is really susceptible to external load. So the curve on a skeletally immature person is a bigger problem than it is for a skeletally mature person. Although if it were big enough, it could be a problem for a skeletally mature person as well. Okay, so what we see here are a couple of drawings representing different types of scoliosis. And what I wanted you to think about with this is what's called a balanced and an unbalanced curve. A balanced curve is, if we consider the drawings on the top, a balanced curve is what you see on the right. And what that means is that the head is on top of the sacrum. So although there is an external moment arm of bending toward the left with that curve of that scoliosis, there isn't a force that is moving the whole trunk to the right, which would be an unbalanced curve, such as you see on the drawing top left. That's an unbalanced curve because the head is actually to the right of the sacrum. So you have an additional torque that is bending the whole trunk to the right. When I graduated physical therapy school in the mid to late 80s, a lot of physicians especially believed that the lumbosacral angle was a big contributor to back pain. So the lumbosacral angle is the angle between the top vertebral end plate of the sacrum and the horizontal, and is usually 30 to 40 degrees. And indeed, there is anterior shear that we experience, especially at the L5-S1 joint, due to the lumbosacral angle, which is illustrated on this radiograph with the angle superimposed on the right. However, whether this actually causes clinical implications or actually leads to back pain only under certain circumstances, because usually, as you see on this netter illustration in the middle bottom, the L5-S1 facet joint is oriented not just in the sagittal plane, but also somewhat in the frontal plane. And this orientation that is somewhat in the frontal plane helps to prevent the anterior glide of the vertebral motion segments above it. Lumbosacral angle can contribute to back pain if there is what is called tropism of the facet joint. So tropism is a broad expression describing when some structure is congenitally the wrong shape. And tropism of the facet joints, especially the lumbar facet joints, usually is describing when the lumbar facet joints actually are oriented in exactly the sagittal plane. And if the S1 superior lumbar facet joints were oriented in exactly the sagittal plane, then there wouldn't be that bony restraint of the L5 vertebra gliding forward in response to the anterior shear that is caused by the lumbosacral angle. So in those cases, the lumbosacral angle actually can contribute. As we age, we undergo a process called age-related disc degeneration. So what happens then is that the intervertebral discs in the spine lose water binding capacity. And that causes the discs to shrink. Not very much each one, but there are 24 of them. So when you add them together, you have significant shrinkage. The average person loses an inch and a half of height in between the ages of 20 and 60 due to age-related disc degeneration. So as that happens, because of the shrinkage of the discs, the thoracic kyphosis increases, the lumbar lordosis decrease, and that causes the center of mass of the upper body to shift forward in front of the pelvis. So there's the center of mass with a young person, and there's the center of mass with the same person a couple generations older. If a patient has a hip flexion contracture, then that patient is not able to extend the hip joint effectively. And now remember, when we think of this, that joints thrive on high compressive forces as long as they're applied cyclically. If they're applied chronically, for several minutes at a time without break, then we are likely to have joint degeneration because the joint fluid squeezes out of the articular cartilage but is never allowed back in because of that chronic high muscular pressure. Therefore, if a patient due to hip osteoarthritis, for example, has a hip flexion contracture, then the pelvis is anteriorly tilted and the trunk tilted forward. And what that causes is a high compressive force on both the hip itself as well as the lumbar spine, because now we need chronic muscular tension in order to hold both of those limb segments upright. There's different postural abnormalities that can happen with the knees. The first picture is genu recurvatum, which means that we're in an unusual degree of hyperextension. Most, especially young, healthy people, have 5 or 10 degrees of hyperextension, but beyond that is considered genu recurvatum. And the consequence of that, as you see with this drawing, is we've got the line of weight bearing going way forward, and then we've got a large moment arm of external extension, which is further stretching out the posterior structures and the ACL and the collateral ligaments, so that knee can become more and more unstable in the direction of hyperextension. Genu varus is what you see in the middle picture, and again, line of gravity and external moment arm, again increasing the external moment. This is actually really common for people to develop with knee osteoarthritis, because as we'll talk about next semester quite a bit, the knee degenerates in the medial compartment usually first. Sometimes with women, it will degenerate in the lateral compartment. So really way more commonly, it degenerates in the medial compartment, and the medial compartment collapses, leading to genu varus. However, sometimes, and as I said, especially with women, you may see lateral compartment collapse leading to genu valgus. That's not the only reason that you see genu valgus, but for whatever reason you see genu valgus, you still have a similar problem of the line of weight bearing going this time lateral to the sagittal, to the frontal plane axis of the knee joint, and increasing the deformity. The final thing that we're going to think about is something that happens at the bottom of the body of the foot and ankle, called posterior tibialis tendon insufficiency or posterior tibialis tendon dysfunction, PTTD. So what happens is, as you see, is progressive eversion of the hindfoot. You see that on the left side in this patient. And that's accompanied with a abduction of the forefoot. Now remember, as we described in anatomy, the foot is really a three-dimensional structure, and pronation has components of eversion, abduction, and dorsiflexion. That dorsiflexion is manifested in the flattening of the medial longitudinal arch because the joints of the midfoot are dorsiflexing. So what happens with that is attenuation of passive supporting structures, and a change on the length tension curve of the tibialis posterior as a result of decreased tendon stiffness. And that allows further progression of the deformity. So if we consider the external moment arms, we see the line of gravity going on the left or the involved side and a very big external moment arm of eversion, but on the uninvolved side, here's the line of gravity, and there we see a very small external moment arm of eversion. These are the points which we talked about first with the first part of our talk, which was released a few days ago, and then with the second part of our talk, which we talked about today.